There's a recent study that was making the rounds on social media, a Swedish study that showed the higher the cholesterol you have, the longer you live. And I think it's useful to talk about why we are so focused on cholesterol and what are we really trying to avoid here. So I'm going to go ahead and share some visuals that I think are very useful. This is an article from the Mayo Clinic, and it's showing us what we really care about here. The top left, there's an artery, and what you're seeing is that you start to get some plaque that builds up just inside the artery wall. So you'll see there's kind of a thin artery wall, and there's this plaque building up there. And as that progress continues, the plaque builds up larger and larger, and eventually it might rupture. So that thin little lining that was holding it in could break open. If that happens, it rapidly creates a blood clot. And you can see in this bottom circle, essentially, there's almost very little room left for blood to flow through this artery. And that's how your heart muscle is getting oxygen, or really any part of your body is getting oxygen. But if this happens in your heart arteries, coronary arteries, then you have a heart attack. So that's really what we're trying to avoid. And I want you to keep this visual in mind because it's really important to understand that. And as a side note, because this blood clot can form, this is why you see a lot of people who've had heart disease on a baby aspirin. The baby aspirin is meant to stop that blood clotting from occurring. What do we There's really two things that we are trying to understand to figure out how we prevent this. What causes damage to that artery wall in the first place, such that this process even begins, and what makes up that plaque? So what's going to keep building up that plaque and make it larger and larger? And spoiler alert, one of those things is cholesterol, which is why we talk about this. But it's not the only thing here. So this is a graphic here from the New England Journal of Medicine. Got it through Open Evidence. And if you all are not aware, Open Evidence is a fantastic tool. It is an LLM. If you're in the US, you can use it for free. It's not available in other countries, but you can just type in any question you have, just like it's ChatGPT. Much better for medicine. It's only trained on clinical medicine. So what causes damage to the arterial wall? I said there's two questions we're going to talk about. What causes the damage, and then what makes up the plaque? And so, first, not actually on this graphic, what causes the damage is super complex. But from the research and the associations we've seen out there are a few things that contribute. One is excess insulin, which is why you hear about this happening more in diabetics. Insulin resistance is a problem. Another thing is inflammation. Okay. Any kind of inflammation. You have an autoimmune disease, you have psoriasis, that's going to make this process worse and more likely to occur. Blood pressure, just sheer force, can cause more damage on that arterial wall, and cholesterol, specifically LDL cholesterol, and even more specifically ApoB, which a lot of you may have heard about. Okay, so that's the damage to the arterial wall. Four things we're talking about: insulin, inflammation, blood pressure, LDL cholesterol. If anyone is at risk of heart disease, we're going to address all of these, not just cholesterol, even though cholesterol is the one that is most commonly discussed. What makes up these plaques? All right, so those are four factors we're going to try to manage if we're worried about heart disease, right? That's the things that cause the damage to the arterial wall, which we definitely do not want because that's how this whole process starts. Then what makes up the plaque? What makes it grow bigger? Well, there's cholesterol, which was also involved in getting the plaque to start forming. That makes up the inside of the plaque. Also, inflammatory cells. So those two things are a double hit. There's a couple other things in the plaque, which is interesting but not as relevant for prevention. There are these smooth muscle cells, and there is scar tissue, essentially. And both of those try to help stabilize the plaque. Your body tries to make it so it doesn't get to this point where it ruptures. It kind of knows that that's not great. In summary, the components we care about: insulin, inflammation, cholesterol, blood pressure, and at later stages, blood clots. So why is everybody always talking about the LDL cholesterol? Why aren't we talking more about insulin or inflammation? There's a couple of reasons for this. One is the LDL cholesterol is involved in both starting the process and it's also involved in propagating the process. So you could argue it's more of a main player. They saw, you know, decades ago, they saw this association more strongly with LDL cholesterol than some of the other things. Secondly, LDL cholesterol is actually a lot easier to define and treat. It's more of a discrete entity than insulin resistance and inflammation. Like, we don't have great ways of testing insulin resistance, which is one of the problems. We use hemoglobin A1C. You may have heard of that, but we just don't we're not able to test it that well. And inflammation, there's a lot of things that cause inflammation. It's sort of this amorphous term. It's not a specific marker. So I think for practical reasons, cholesterol gets discussed a lot. But I want to emphasize that it is the combination of all these things that truly leads to disease, which is why I think sometimes you see examples of people with high cholesterol, but then on their imaging, they don't have any plaque. A lot of people are on the ketogenic diet, for example, or carnivore diet. You'll see them put their blood markers up and say, look at my imaging. There's nothing here. See, cholesterol isn't the culprit. Cholesterol is necessary, but is not sufficient for the disease process. It's never really a bad idea to lower it. And we're going to talk about this in the next part of different ways you can lower it. But if you have high cholesterol in the absence of the other risk factors, you may not have atherosclerosis or this plaque that is clogging up your arteries. So that's really what I want to emphasize to you all. And ultimately, kind of as a public service announcement, I think it's important that yes, these studies are out there that might guide you into different decisions, but you can actually go get imaging done. You can get a coronary CT angiogram, a scan that shows you what's happening in your arteries. And you don't have to do a lot of guesswork. Costs a little bit of money. You might be able to get a prescription from your doctor to get it. Your insurance might cover it. But ultimately, that is the real source of truth. That is the gold standard. You can get a test to see how much of your arteries and how many of them are actually clogged versus not. And then you can decide if it's worth it to try to lower your cholesterol or work on your insulin resistance or inflammation if you have any of that.